Welcome to Senadhipan Education Foundation. Education is the passport to the future, for tomorrow belongs to those who prepare for it today. So we have started this educational program way back in 2012 by releasing a set of educational DVDs. The release ceremony was by Dr. Sion Han Kim from Korea at Taj Vivan at Trivandrum. Then he visited our place in Holy Cross Hospital, Kottayam. And we used to have contact classes and training programs in our hospital. Because of the COVID, we changed to online programs. It was actually, the logo was released by none other than Dr. Palanivelu.
Professor Palanivelu, sir, Chairman, GEM Group of Hospitals and Research Center, and the Founder President, MRC, for releasing the logo of Senadhipan Education Foundation and for the inaugural address. Over to you, sir.
Thank you, Nisha, and thank you, Baiju, for inviting me to be today's remarkable event, part of this. And Bush, good friend of mine, and since he started laparoscopy, we're very happy about it. Dear friends, Parvinder Lal, Vice President of National Board Examination, and John Abraham, ASI.
Then onwards, we used to have online lectures with world-renowned faculties. We used to stream live surgeries through the online platform. And we used to conduct certificate courses. Actually, we have a very good global acceptance. These are the countries the delegates logged in. Last meeting, almost 900 people logged in. Actually, we have two WhatsApp groups of 256 each and one Facebook group of 655 members. Today, we have two eminent personalities for the webinar. You all know Dr. Ramesh Ardhanari. He is the department of head of the department of surgery and gastroenterology. Actually, I visited his department way back in 2004 just to meet him. I was surprised to see the name of the department. It's named as Surgery and Gastroenterology. So gastroenterology is, even medical gastroenterology is very close to his heart. And I was surprised to see that he is doing a lot of endoscopy work, therapeutic endoscopy work. That time US was not available. Later he started doing endoscopic ultrasound also in Meenakshi Mission Hospital, Madurai. Now he is presently the president of Indian Association of Surgical Gastroenterology. He was the past president of Association of Minimal Access Surgeons of India, which is a big body in minimal access surgery in Asia. He has got a lot of research works and a lot of citations. Actually, he visited, this is a photo when he visited our hospital in 2009. He is a versatile lab surgeon, does everything from esophagus to anus, liver, pancreas, everything. Therapeutic endoscopist. He is a mentor to many medical gastroenterology experts. You must have seen him, loved his fun in many conferences. When he cracks jokes, he is a regular attendee and a demonstrator in all the live workshops. And we have another eminent faculty, renowned faculty all over the world, who is the inventor of NODS. He is the director of Asian Institute of Gastroenterology, Dr. G.V. Rao. He is a B.C. Roy awardee, awarded by the President of India. He got another award recently, Waiting in the Line of God, New Indian Express Award. He is a world expert in open surgery, lab surgery, and therapeutic endoscopy. He is the immediate past president of ISPBA, and he is a policy maker in many of the international bodies. Our next meeting is by Dr. Adarsh Chowdhury, whose the anastomosis leaked. It will be moderated by Dr. V.K. Kapoor, with the Professor of Department of Surgical Gastroenterology, Sanjay Gandhi, Postgraduate Institute of Medical Sciences, Lucknow. And after that, we will be having Professor David Kion will be talking about tips and tricks of liver surgery, lap liver surgery. David Kion is the director of laparoscopic liver surgery in Cleveland Clinic, Ohio. Before we are starting the instruction to the participants, all participants are requested to mute their mic on entry. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene in between talk or session. Everybody will be given permission to unmute. That is the importance of, that is the beauty of this webinar. Everybody will be given permission to unmute and ask questions. If you are on a portable device, please mute your audio, hide your video. Please mute your video if you are not in a casual dress event. And if you can contact us by senadiman@gmail.com, and all the webinars will be available in the Senadiman Education Foundation YouTube channel. Please subscribe to the channel. Over to the moderator, Dr. G.V. Rao.
Good evening, everybody. Thank you so much at the outset. Let me thank Dr. Beju for the honor of this meeting. Thank you, Dr. Beju. It's been an incredible journey for the Senadipan Education Foundation, which was started. And the amount of academic work that the foundation has been doing is phenomenal, and it is reached across the globe, and it is acknowledged by several of the participants from across the globe. And if you see the number of participants that has been involved in this meeting, and it has been rising phenomenally over the last few meetings. Congratulations, Beju, for all this. It's a Herculean task. I know how difficult it is to start this program and keep it going. And at the same time, you can see that the faculties which are accepting to this foundation lectures are from across the globe. It just speaks volumes of the good work being done by Dr. Beju. Congratulations, thank you. And thank you, Dr. Beju, for getting me onto this panel. Let me introduce Ramesh. Actually, Ramesh and myself, actually, we have been associated for more than 3 decades. The association starts way back when we were together in Chennai with Professor Rangabhasham. So it's more than 3 decades. And in the last 3 decades of practice, one thing very common between myself and Dr. Ramesh seems to be endoscopy. Both of us seem to be very passionate about endoscopy. Initially, when we were involved in endoscopy, people used to raise their eyebrows as to see why surgeons should be doing endoscopy. But over the period, once the medical gastroenterologists started dominating this, and more of these therapeutic procedures being done endoscopically, now surgeons who raise their eyebrows against surgeons doing endoscopy seems to be falling back, and they think now surgeons have to practice endoscopy. But surprisingly, again, endoscopy was started by surgeons, but because actually surgeons didn't have much time to devote to this, and actually surgeons thought it may not have a very big role in practice, I think they left it. But even today, if you see the statistics, actually almost 60% of the endoscopy practice across the globe is done by surgeons. And this is officially documented by the industry which sells the endoscopes. Actually, it is more than 60-65% of the practice is done by surgeons. So it is started by surgeons. Actually, even now, I think a fair amount of endoscopy is being done by surgeons. And there are a lot of positive things about surgeons doing endoscopy. Once you start going from lumen outside the lumen, as long as you're staying within the lumen and you're doing some diagnostic work, it is different. But once you start doing some advanced therapeutic work, I think we should have some fair amount of surgical skills before you attempt these things. Ramesh is presently the medical director of Meenakshi Mission Hospital. incredible laparoscopic endoscopic work he's been doing, incredible number of surgeons he has trained across the country, across the globe, phenomenal publications from his team, and the amount of clinical work that was done for Meenakshi Mission Hospital was phenomenal, both on the endoscopy side and laparoscopy side. And thank you, Ramesh. Actually, we are both passionate about endoscopy. Let us, one message should be clear at the end of this webinar is that surgeons should not leave endoscopy. It is their domain. We should continue to practice, and we can show that the overall outcomes of these various therapeutic procedures are better when surgeons are doing endoscopic procedures as compared to their medical counterparts. So it's a beautiful webinar. I feel already more than about 200 people have logged into this. Ramesh, the air space, the screen space, and Baiju's foundation space is all yours.
Thank you, GB. I must start by saying that I will congratulate Baiju. There are two people who have taken surgical gastroenterology to the masses, to the social media. Baiju is one of them, and Patta Radhakrishna from Chennai is the other one. And these two have done yeoman work because so much knowledge is going from senior faculty members to even when I listen as a faculty member, I learned so much from these seminars. So I can imagine how much the juniors would learn. In a way, the COVID seems to have has benefited because we actually have more people listening to these lectures than actually in the conferences where most of the people are traveling outside, standing in the stalls, having gas sessions, and not really attending the meetings, which is we have seen. And here we see a dedicated bunch who are actually keen on learning. And it's such a pleasure, and I congratulate Baiju once again. GV is a pioneer in endoscopy, one of India's leading endoscopists, and I had his, to a large extent, the endoscopy that I practiced in the initial years was what I learned by myself, and then what I improved by my visits to the workshops at the AIG in the endoscopic, and where I saw new gadgets, new guide wires, and then I would come and try to improve our services. And I have to say that I owe a big credit of gratitude to Nagi Reddy and G.V. Rao for that, because I think they expanded my endoscopic horizon, and to Palnivelu, who expanded my laparoscopic horizon, and to Surendran, who expanded my open surgery horizon. And I owe a great debt of gratitude to them. GV said that surgeons should be into endoscopy. So when I show you the title of my talk, you will find that it's provocatively placed. And I don't say that surgeons should go, but I make a definitive statement that surgeons must perform endoscopy because this is what I feel and this is what I think that we are coming. Now, if you look at gastroenterology as a whole, as a specialty of the GI tract, you will find that there are 4 major therapeutic arms that have come in the last 150 years in the treatment of disorders of the gastroenterology. I'm not talking of diagnostic arms, I'm talking of therapeutic arms. And one is drugs, which mainly our medical colleagues use, but which we also use. So we have a lot of new drugs which are used for inflammatory bowel disease, for Crohn's disease, you can name it. And we have new, very effective agents for these. And these have, in effect, reduced the number of cases who actually require surgery. Of course, there has been open surgery and it has progressed tremendously. There was a time when in the 1990s, liver transplant was done in 1 or 2 centers and most cases were failures. In 2020, the city of Madurai has 5 transplant centers, and the state of Tamil Nadu has over 30 transplant centers. And across India now we have close to maybe 100 transplant centers, and all doing high quality work with results that can match the American and European and Japanese results in transplant. And I think that is one of the great advances. But open surgery has been for a long time the mainstay. But then in between there was endoscopy, which the surgeons didn't come very close to, and I'll show that in the next slide. And then, of course, the age of laparoscopy began in the 1990s, and in 30 years, it has become de facto the king of surgery. And if today you are a general surgeon, you can't be, or a gastrointestinal surgeon, or a urologist, or a pediatric surgeon, gynecologist, you can't do practice without doing laparoscopy. In every field, you require laparoscopy. But I'm going to show that the same amount of importance has come to endoscopy. Some of you, most of you will be aware of it, but may not have formulated exactly what it has done. But endoscopy has come to stay. Why is it that I have to speak on this? It would have been natural for surgeons to do endoscopy. We do dissection in the open surgery and in laparoscopic surgery. We do hemostasis, we excise tissues, we reconstruct tissues. We are taught this from day one of our MS. A medical gastroenterologist learns it only from the time he becomes a DM student in gastroenterology. So we have an advantage in that we start with it, and that's what we deal with daily. So why is it that we are not doing it? Why have we lost it? And I can only put it down to surgical hubris of our senior surgeons in the decades of the 50s, 60s, and 70s. They looked at these thick, unwieldy endoscopes with poor light quality, fiber optic, where often fibers are broken and there are black spots, and the surgeon peering with his neck straining, the physician peering inside. And they said, this is nothing, this will not do anything. Let the medical people do this and we will leave it. And that is where we fell. Because we forgot the most basic rule of technology. Human beings are brilliant at innovation. The idea comes to few. But then once the idea is established, improving upon that to do better things comes to a lot of people, and they quickly change the face of that technology. It is only in 1907 that Orville and Wilbur Wright flew a plane for less than a kilometer. Today, we all routinely fly in aeroplanes for 10,000, 15,000 kilometers. We have reached the moon, we have walked on the moon, we have reached Mars, and we now have spaceships that are heading towards Venus. We have motor cars that in the early 1900s were objects of the rich. In those days, the poor went by horses. Today it has changed. The rich go by horses and ride and have their pleasure, and the middle class and the poor drive around in cars. Cars are moved from the old cars to the Teslas and the Benzes with their safety features, with their driverless driving, with their ability to prevent accidents by sensing the crossing of a human being or an animal and putting on brakes before the human brain can react. So similarly, endoscopy has been developed. It was a diagnostic school when we were doing post-graduation. Today, it's a therapeutic machine. Among surgeons, if you look about, you find that urologists were smart. They didn't allow it to go to medical people. They did all these procedures, that developed the telescopes, developed the guide wires, and made sure that the entire field of therapeutic work on the kidney and the bladder stayed in their domain, and they improved upon it. Even 50 years ago, they were doing open surgery. but they rapidly adapted to minimal access surgery, to using the telescope. They were smart. Most general surgeons and even the so-called evolved cardiothoracic surgeons were not so smart. They forgot that their professions could be in danger. In the 80s, across Europe and across America, cardiothoracic surgeons were the highest paid doctors in every hospital you could see. In 2020, they have dropped out of the top 10. They are, many of them, my friends tell me that they just sit in their theaters in various rooms and play poker because they don't have work. First, stenting took away CABG. Next came trans arterial, ASD repair, VSD repair, aortic valve replacement, and slowly, a lot of work that was done by cardiothoracic surgeons has been taken up by cardiologists. So flexible endoscopy today is not merely a diagnostic tool, it's an invasive procedure. It does involve in the therapeutic procedure, dissection, removal, and reconstruction. We learn anatomy, dissection, suturing right from day one. Medical gastroenterology only learn it when they go for DM. And even then, they never try to master the knowledge of anatomy. So you ask the ERCP person, 9 out of 10, I'm not saying all of them, you ask them what lies under the ampulla, how is the ampulla built, many of them will struggle to give you a good answer. During MD, they don't concentrate on tissue approximation, anatomy. I am going to give you the stand of the American Board of Surgery in regard to endoscopy. So this comes from the foremost country in the world in innovation of new procedures in endoscopy, new endoscopes, and look at what they have to say. Endoscopy was developed by surgeons. Surgeons have made major contributions, continue to make to them. These have included the treatment of endoscopic treatment of variceal bleeding, first done by surgeons, polypectomies, tattooing for colon cancers, ERCP, many other procedures. They are intimately aware of the anatomy during doing open and laparoscopic surgery, and they have, I believe, they start with an advantage over the medical gastroenterologist in doing advanced therapeutic endoscopic procedures. Now, let us take a look at the United States, and this is a statement from the ABS made about 3 years ago. In the United States, gastroenterologists are rarely available in rural and underserved areas. In such areas, surgeons may be the only providers of indispensable endoscopic services. This is true of USA. It's even more true of India. We have maybe 200 seats across the nation in DM gastroenterology. Multiply that by, say, 20 years of working, you will have 4,000 GI practitioners who have DM gastroenterology across the nation. Our population, 1.3 billion. Our 4,000 people can handle all the endoscopies of these people? Impossible. So, we require a cadre that will do these procedures. At least do diagnostic endoscopy, emergency therapeutic endoscopy, and some easy therapeutic endoscopy. They need not all do ERCPs and ESDs and EMRs. But they should be able to do a colonoscopic polypectomy, band a varix, inject a bleeding duodenal ulcer in an emergency. And no MD physician is going to do that. They are not interested. MD physicians are interested in the kidney and in the heart. Nobody else is going to do that who is present in large numbers. General practitioners are not going to do that. So the ideal force that exists is the surgical force. We have 125,000 surgeons at least across the country. We can train them to do these basic procedures. Then the medical gastroenterologist can do and spend more time in doing the complicated procedures. This will allow them to have more time to do the procedures, will shorten waiting times, and will improve their ability because they don't waste their time doing diagnostic work. So this is what is the situation in the United States. I think it's even more so in India. So given that many of the diseases are ultimately treated by surgeons, a surgeon should have an early involvement in diagnosing and seeing what is happening. To give you two critical examples, you will often get an information from a medical gastroenterologist on an endoscopy, growth seen in the stomach, biopsy taken, impression cancer stomach. As a surgeon, what am I interested in? I am interested in two things. Is the growth possible? Not possible. Is the duodenum free? Not free. And most important, I want to know the length of the stomach that is normal from the upper edge of the growth to the OG junction. If this is 5 centimeters or less, then this patient needs a total gastrectomy. Now, this information is very rarely given in an endoscopic report, unless the surgeon has performed the endoscopy himself. Why is it important to know whether we should know this before surgery? I might ask a postgraduate to start a distal gastrectomy, and I might stay in the outpatient department and do my work. But if there's a total gastrectomy to be done, even if a postgraduate or a junior consultant starts it, I would like to be around to see the resection and make sure that he's done a good job. And I think that knowing this helps me to plan my work, not take an on-table decision and then after opening the junior calls and says, sir, I don't know whether to do a total or a distal. This decision has to be taken pre-operative. We should know this before. So this is the importance of the surgeon doing endoscopy. Secondly, is the precise measurement of the distance of the rectal tumor from the anal verge. Most people just look at some marks on the endoscope and say 14 centimeters, 12 centimeters. That's not good enough. I want the endoscope to be held and then a scale placed from the tip of, keep the endoscope at the tip of the growth and then pull it out. And from where you put your finger at the anal verge, I want a scale to measure that, and that has to be documented. Because that tells me this is a clear anterior resection, clear abdominoperineal resection, where I can do a trial anterior resection. This information is mandatory for surgeons, and I prefer to do at least a repeat sigmoidoscopy myself before I take a final decision, if the figures are not given as I want. Most of our gastroenterologists are now trained into what surgeons want, so they give us the information. But if you have centers where it is not done, then you may have to do it yourself to do this. So these are two small areas that I have brought, and we can help them. Secondly, there is often a complication following endoscopy. And yes, endoscopists have got good at managing their own complications, but now and then we are called in, and the surgeon, if he was doing the endoscopy, he would be able to immediately do the repair. Whereas sometimes if the gastroenterologist does, he hopes and prays and postpones the decision for a few hours, and the patient becomes sicker. When you look at the quality, GV already made a mention that the quality of endoscopy as done by surgeons is equal to the quality of endoscopy done by GIs, gastroenterologists, medical people, endoscopists, and that is true. When you look at various studies, and these are large studies, Wexner looked at 13,580 lower GI endoscopies performed by surgeons, and found that the standards we look for, complications, ability to reach the CECOM, total procedure times, were all the same as for the medical gastroenterologists. Pediatric gastroenterologists have done the same. The surgeons have equaled whatever the timings and results of pediatric gastroenterology is. So we have now evidence that surgeons can do a good job. So that is no longer an excuse. They've shown that the number of polyps missed is the same whether it's done by surgeons or by medical gastroenterologists, and there are no differences in this group. The American board therefore says that they're committed to high quality patient care, patient safety, unimpaired access for the public to medical care, and they want to train their surgeons into endoscopy, and they will embed it in their certification program, and they will have appropriately trained surgeon endoscopists to train and to give comprehensive care to serve the public need. I think this is a very important document. It is exactly the same situation in India, even worse. We have much more population, much less gastroenterologists, and a large group of surgeons who would be happy to do this, provided they are allowed. But unfortunately, in many centers, surgical people are not allowed in the endoscopy room, and the certain surgical endoscopic societies have passed resolutions that surgeons should not be allowed to do endoscopy. A group of medical gastroenterologists in Tamil Nadu wrote to the health minister that surgeons should not be allowed to do endoscopy, which I think is ridiculous. And this is just like the gray area that you have a CA rectum or a CA stomach. It could be done by the surgical oncologist. It could be done by the colorectal surgeon. It could be done by a surgical gastroenterologist. So all you need is that you need somebody who is trained to do the procedure. It is wrong to stop a person who has training to do the procedure. We certainly, no individual group can manage all the diseases that we see in that area. So it is important that adequately trained people can look after. And that, I think, is the most important thing that we have to have. And let us take a look at procedures almost completely taken over by endoscopists. This is important because it will give you an idea of how much of your surgical practice has now disappeared or is in the process of disappearing. So in the upper GI tract, GI bleeding from varices or ulcer is almost completely treated endoscopically. Palliation of CA esophagus is done by endoscopy. Endoscopic GJ is now starting to come, and there are many centers in India which are doing this as a palliation for CA stomach. Provided they can get the guide wire across the duodenum, they will be able to do an endoscopic GJ. The only thing that stops it from becoming more popular in India is the cost. But once they bring the cost down and Indian people start producing this equipment, you will find that a lot of these procedures are going to disappear. Achalasia cardia. Balloon dilatation was the first that took away a vast chunk of patients. Then came POEM, which was virtually a surgical substitute, and that took away a large segment of pain. I know that in many centers in Bombay, in Hyderabad, in big cities, achalasia cardias are done exclusively by POEM. We don't have a training for laparoscopic Hellas myotomy. But how many people do achalasia cardia by POEM? If you count it, you will find that in the country it is less than 50. Whereas you could train laparoscopic Hellas in a force of senior general surgeons and laparoscopic GI surgeons to the extent of about 2,000, 3,000 who could take care of them with safety and with good results. So we are channeling it to one area only, where not everybody does, only few people do. I think there's a big disadvantage. We are seeing now more and more endoscopic procedures appearing for GERD, for Barrett's esophagus, for early stomach and esophagus cancer, endoscopic submucosal dissection, endoscopic mucosal resection. So this entire group of diseases is now moving from the surgeon to the interventional endoscopist. In the biliary tract, CBD stones are almost exclusively dealt by ERCP, and only when they fail, surgeons come in to do either a lap exploration, open exploration to do it, but it is only about 5% of all the patients. 95% is gone. Pancreatic cancer stenting for obstructive jaundice is virtually never done surgically now, excepting when we open up the patient to try to operate for cure and we find that it is not possible, we may do a surgical bypass. Otherwise, we never post the patient for a surgical bypass. They are stented endoscopically. If they can't be stented from the ampulla, they'll be stented from the liver with a PTB. Bile duct strictures, after the work of Guido Costamagna from Italy, many patients are now being managed by endoscopy. But endoscopy has its disadvantages. You need 4 or 5 sittings of endoscopy over a period of 2 years. You need multiple stents. You have complications of those endoscopies. And at the end of it, the overall results is around 70%, whereas the results of surgery are about 80% in the whole group that undergoes surgery, which includes 3 and 4 strictures of the grade 3 and grade 4 strictures of the bile duct, which are not done well with endoscopy. Whereas endoscopy takes the best of the cases and can only produce a 70% result after multiple procedures. In those patients where they say they can produce 70% results, a surgeon who's trained in hepaticojejunostomy can virtually produce as 95% completes a cure for the stricture for the rest of their life. There has been an interest in endoscopic cholecystectomy, fortunately not taken up very much, but some Chinese surgeons have started doing transcolonoscopic, reach the hepatic flexure, puncture it, then reach towards the gallbladder and use fine instruments through the endoscope to do an endoscopic cholecystectomy. Endoscopic hepaticogastrostomy, on the other hand, has become very popular, and they can take from the stomach with under endoscopic ultrasound guidance the left lobe of the liver, puncture the duct and produce a self-expanding stent between the two. As a matter of fact, I saw a paper which presented in Seoul from Germany, 25 grade 4 injuries of the bile duct after cholecystectomy. They went in with an hepaticogastrostomy, allowed the tract to mature for about 3 weeks. Jaundice came down. Then they took a thin endoscope with which they went through this tract into the liver up to the hilum where they could see the block. Simultaneously, an ERCP is done and a guide wire is placed in the hepatic bed through the remaining bile duct. Then a blind puncture is made from the liver with a lasso type of instrument, catch this guide wire, pull it into the stomach, and then over this put a self-expanding stent from the hilum of the liver to the duodenum, and then allow this to form over a period of 9 months to 1 year, a nice bile duct tract, after which it can be removed. And the success rate of this was about 90%. So we are seeing even complex strictures of the bile duct now being treated endoscopically. In the pancreas, treatment of pancreatic pseudocyst or walled-off pancreatic necrosis is taken over by the gastroenterologist, and we get very rarely a chance to do a surgical procedure. In chronic pancreatitis, though the evidence says that it is not an effective treatment, every patient goes for stent and ESWL, and only if they fail, they come to the surgeons, by which time surgery can be difficult because they've got infected systems, they've got thickened tissues due to inflammation. The small cystic neoplasms which used to be operated or observed are now destroyed by injection of absolute alcohol, and small net tumors are destroyed by alcohol. Pancreatic duct injuries are managed by ERCP. If they can cross the injury, they can put a stent across and act as a bridge for the stent to grow. And in patients with pancreatic pain or other cancer pain in the upper abdomen, EUS celiac access block or EUS FNA to establish the diagnosis has become a standard of care. When you look at the colon, the management of single or few polyps is almost completely gone from the surgical side. They are usually managed by endoscopy, and endoscopies are so much improved that even if they cause a perforation, they are able to diagnose it and manage it with clips endoscopically with very good results. So they not only now do the polyps, but even they don't have fear of the perforation because they are able to clip the hole. Obstruction is there in the colon due to cancer. They can put a stent across and tide the crisis. They can derotate a sigmoid volvulus and tide the crisis. Lower GI bleeding, they can either use a colonoscope or use a enteroscope from the mouth, and they can cover almost the entire small intestine, find the source of bleeding, and sometimes even they can therapeutically treat it with injections or other treatment. There has been some reports of a colonoscopic appendicectomy and of colonoscopic cholecystectomy, as I already told you. So, how is it that they have managed to do all this? What is the reason? It is because of the innovation that the endoscopes have had. This is the view that you would not have seen in 1990. You would have seen a fiber optic view, broken black spots where the fibers are broken, and you will have to put your eye to it, and you can't maneuver it into various places. But look at it today. The high definition image, the processing of the computer chips is much faster. You can change the color of the light that you shine on the tissue, and by that you can make, as you can see, vessels stand out and areas which are not looking normal. In the lower image, you can see this area which doesn't look normal, and you can do a submucosal dissection for this. Now, this is not seen clearly on the normal image, whereas on this image with the NBI, you can actually see this. And then you can have improved therapeutics because of the companies making APC, water jet, gold probes to cause hemostasis, hemoclipping. Now, we used to have for the last 2 decades only small clips that could just about hold the mucosa. But now they've come with the over-the-scope OTSC clips, which can take a full thickness bite, and one clip can close a hole in the stomach or in the esophagus or in the colon nicely and tightly, and it can. So the clips have improved. So what we have got is better endoscopes which handle better. With lesser diameter, they give you a better image. They give you a full screen image. You can do magnification. You can change the color of the light. You can do confocal, where you can go close and look at the cellular pattern. So you have got everything available at your fingertips. And this is something that was not there 20 years ago. And the next great advance has been endoscopic ultrasound. Somewhere around the 2000s, initial equipments were bulky. They were just for diagnosis. They just had a radial ultrasound. They were useless for anything else, but they were very expensive. Still, a lot of people invested money in it. But then the companies realized that unless you do therapeutic, not a lot of people are going to buy this. So they brought the linear echo endoscopes, with which we could do procedures under endoscopic guidance. So what did it mean? So you had a pseudocyst. Either you could not see the bulge of the pseudocyst on the stomach, in which case the endoscope allowed you with the ultrasound to see where the pseudocyst was present. And it allowed you to see the intervening wall, whether there is a blood vessel or a vein in that wall. And then you could puncture it safely where there is no vessel. And then you could put a stent, and most of these pseudocysts would get healed. You had pancreatic cancer, which we couldn't reach with normal CT or ultrasound to take biopsies. And you get a beautiful endoscope which sits next to the pancreas, guides you into the tumor, and you can take. And with having the pathologist sitting in the endoscopic room, the immediate staining, they could tell whether cells were present. And if they were present, they would tell you within 6 hours the results. So you could happily go out of the patient once you had the cells. And you could do ablation. You could destroy celiac axis. in a radiology, the destruction of the celiac axis is always a presumptive celiac axis, because you don't do an angiogram to destroy the celiac axis. What you do is that at a particular level, you go along the rib and then you inject the local agent and see whether the pain is gone. Here, you go with the endoscope, echo endoscope, keep it in the lower esophagus, and you can see precisely where the celiac axis takes off, and you can inject the drugs around the celiac axis precisely, so that the improvement of destruction of the plexus is far superior and pain relief is far superior. We could, with endoscopic ultrasound, diagnose the stage 1, the stage TIS, T1, TIS, and we could decide which patients will benefit most from endoscopic resections. And so EMR and ESD became safer and more accurate. So you had a lot of advantages of endoscopic ultrasound. We purchased our first ultrasound in 2006, and we took some time to stabilize it. And this is some of the images in the old ultrasound which we had first, which was a Hitachi, and you can see the dilated common bile duct here, marked CBD, and the complete narrowing here. This is a stricture, maybe a malignancy setting there. You can see here the full bile duct seen next to the in a long view. This is probably a colorectal cyst, and this was operated for a colorectal cyst. And this is, you can see a mass in the pancreas, which we are using a needle to do a fine needle aspiration and take a biopsy. And there's another mass in the near the duodenum in the pancreas, from which we are taking a biopsy. The same thing again. What we lacked was that we couldn't see inside the bile duct or the pancreatic duct. And then came this wonderful machine called Spyglass, which allowed you to enter into the bile duct and enter into the pancreatic duct and actually see the stone or see the stricture. And then from the stricture, you could use a fine rat tooth forceps to take a piece of biopsy. From the blind brush cytology to the directed punch biopsy, tremendous improvement in rates of diagnosing cholangiocarcinomas. So most cholangiocarcinomas we would treat with presumption based on imaging. Now we have a way to treat with direct evidence that this is an adenocarcinoma or this is a benign tumor. And these stones, big stones which are obstructing the duct, we had to do blind lithotripsy. Now we can do a directed laser lithotripsy through the Spyglass, and we can get away with excellent results. So then one of the big problems in the West, and I'm sure that we are seeing more and more of these cases over the last few years of Barrett's esophagus. And if the Barrett's esophagus shows high-grade dysplasia, the original treatment is only esophagectomy, which is a major morbid surgery. Patient has a lot of post-operative problems in swallowing, their weight never picks up. And now we have a number of treatments endoscopically where we can burn the mucosa completely with these, say, halo photoablation. And then the new mucosa grows and the Barrett's disappears. If it doesn't, then we can think of surgery. And small bowel imaging. The enteroscope I already talked about, by which we can reach any level. But if you just want to make a diagnosis, you don't want to take the patient for an enteroscopy, you have the pill cams, which could go in, and now multiple companies make it. And these are very effective in finding out the source of the bleeding. And now they have these beautiful computer algorithms which actually tell you where it is bleeding and how much is bleeding. So you don't have to look at each slide to know whether it is, the machine will tell you. So it is really something that has changed our approach to the management of obscure GI bleeding from the small intestine. So what is the future? And this is important for the youngsters, that we are looking at a future which is going to be more of minimal access surgery. It's going to be laparoscopy, or it is going to be endoscopy. Many of the laparoscopic procedures will be done endoscopically. Achalasia cardia, classical example. CBD stones, classical example. Polyps of the colon, classical example. So these are all going to be done. And we are going to find better methods to do them safer and more accurately. And technology and equipment changes so rapidly. We had standard definition, then we had high definition, now we have 4K definition. And I believe that the endoscopes are coming from Europe, which will have an 8K resolution. The 8K resolution is superior to the resolution of the eye. So that is something spectacular to look forward to. So your vision is going to be much better than what you will ever see with your eye or with an ordinary endoscope. So you're going to have fantastic equipment to work with. And these will be complemented by fantastic methods of doing hemostasis. One of the main problems with therapeutic endoscopy is if you are bleeding, you get blind. Now we are getting sprays and medicines which can very effectively stop bleeding temporarily and allow you to do the work. You have emergence of therapeutic fellowships which will teach you to do these works. Notes, its place is still coming, but I foresee that in another 10 years, notes will again come back. Notes is a technology whose time has come. Poem is notes technology which has really taken off. ESD, EMRD, they're all working in the notes third spaces and they're taking off. It is only a matter of time before we find secure closure devices so that we can do more notes procedures on gallbladder, appendix, and whatnot. So I think that the age of notes is not gone. It has suffered a temporary setback because of the lack of funds, but it will come back. There will be improved therapy of malignancies, cystic lesions, which will be done. So the patient who doesn't need a major surgery can be palliated with endoscopy, with endoscopic ultrasound, is much better off. He can come in the morning, go in the evening, be pain-free, and in his limited life of 7 months or 8 months, he need not spend a month in hospital, which I think is going to be very, very important. So you see this notes. So these are, you have to perform the surgery through the natural orifice, and that could be urethra, which the urologists have been doing notes for years. They've been doing transurethral resection, removing stones in their ureters, doing ureteroscopy, retrograde renal scopy, whatnot. They have reached the kidneys calyces from the urethra. So they are actually at the forefront of notes. And I think that from that example, I think we are going to come back to notes. And I think that whatever we see now that notes is not being done is a temporary setback. And I feel that with technology in the next 5 years, you're going to see more of notes. So who will perform these surgeries? This is what I am trying to bring back to you again. So it is natural that from open surgery, we move to laparoscopic surgery, and we will move to natural orifice surgery. And so we are the people ideally positioned to do these procedures. But if we don't get into it, if we avoid it, there will be somebody who will get into it, and that will be the medical gastroenterologist. And then once they get their hands on it in your hospital, they won't allow you to touch it. So you have to stay in the game right from the beginning. As even if they do, you should also do. So you should stay as equal partners. Now, one of the main reasons why this is not done, why are surgeons avoiding endoscopy? Because we depend on the medical gastroenterologist to refer you the gallbladders, the reflux esophagitis, and whatnot. So this is a fear that most people have. But I can tell you that this fear is a little overrated. Because if the patient really requires it, they are in no position to deny it. The patient will really come to you. And I often hear the complaint that they don't refer GERD to us. They keep managing them medically. They keep managing them medically because the patient is happy to take the drugs. If the patient is unhappy, they won't stay with the gastroenterologist. They will seek somebody else's opinion and come to you. I think that surgeons are over keen to operate on GERD because it's such a nice operation to do laparoscopically, but that's not an indication for an operation. The indication should be that it should be needed. And I think that we try to do too many GERD surgeries, and we don't really need so many surgeries. But once you get into a position where you do your endoscopy, you have your practice, and you diagnose your GERD, your patients will come. You will have a group of patients who will do, and you will be able to do their own surgery. And in many smaller cities, you won't have medical gastroenterologists. So you don't have to send them 200 kilometers to get an endoscopy. You can do the endoscopy yourself. So now a number of procedures like transgastric appendicectomy, G.V. Rao is the first in the world to do it, but many others have now followed suit. Transvaginal cholecystectomy, transgastric cholecystectomy, and this is a video from the first gastric appendicectomy from G.V. Rao that I got, and I don't need to show that. You've all seen it many times, but it's a matter of pride that it came from India first. So I think we should keep it. We are going to see endoscopes evolve into having multiple channels, ability to stabilize them with rods and stands into different positions so that they don't keep moving. And then we can use multiple channels. It may be just a 2-channel endoscope, but we can always put a 3rd channel on top of the endoscope. We can add it at the time of the procedure. It is now routinely available, these channels. And we can use that to hold tissues and then lift them and cut them. So now we do endoscopic mucosal dissection. We inject the drug and then we cut the mucosa and we just keep going underneath it, sort of tunneling under it. But once we have 2 channels and you can have 2 instruments, and I know that GV and Nagi have been worked with Pradeep have been working on this sort of octopus type, where the surgeon has 3 or 4 controls in his hand, and somebody else holds the endoscope, and then they can lift the tissues and cut the tissues and stitch the tissues. I think we are moving towards it. We will move towards it. This is going to be the demand, and once it is the demand, companies will invest in it and start making it. They have come to robotic surgery in laparoscopy, but a robotic surgery in endoscopy is coming in as a platform again, on which it's coming from a Singapore company and a South Korean company, and I know that GV and Nagi have been collaborating very closely to work out this and to bring it to the market. And I think that it is going to make endoscopic surgery much easier. Yes, it is going to be costly. But 2 years back, we had hardly 5 or 6 robotic installations in this country. Today, we have more than 100. So the money is available now. People are willing to invest, even if it means going at a loss, because you want to provide that extra support to the patient. So this is going to come. And once more companies come, you will start finding instruments being made by other 3rd companies, which cost less, which can last longer, which won't have the 10 case limitations. And you will, as you improve, you will be able to do better work. And I think that the future of surgery will be in robotics, because there are so many advantages. The surgeon is sitting, and even if the surgeon has a shake, the instrument doesn't shake. So you can have a very precise, good suturing without instrument shake, and even maybe you can do vascular reconstructions robotically. And I think the time will come when more procedures will be done by robotic control. And we may even see that the balance will shift from laparoscopy to robotic surgery. I know that Palni Velu, who used to be so much against robotics, 10 years ago, he would always get up and make a comment against robotics. Today, he's a rabid robotic supporter because he has seen the advantages, the ease of the surgery. And I think that is what is important. And the same thing will happen when you get the robot into the flexible endoscope system, and it is going to come. It is not very far off. May not be in my time, may not be in G.V. Rao's time, but I'm sure when the younger surgeons who are just qualifying, who are just becoming surgical gastroenterologists, 15 years down, they will be doing all these procedures. Please remember that when G.V. and I trained in MCH gastroenterology, there was nothing like robotic, nothing like laparoscopic surgery. As a matter of fact, I was asked by Professor S.P. Kaushik of SGPGI in my exam. Tell me something I don't know. So I thought for some time, and then I remembered reading the small letter in the Lancet about the French surgeon who had performed, Philippe Maury, who had performed the first the laparoscopic cholecystectomy. So I told him that there's a French surgeon who I didn't remember his name. I said, I read a letter in the Lancet, sir, there's a French surgeon who has done a laparoscopic cholecystectomy to just 4 holes, no incision. And he has used special instruments, and he is visualized with a telescope on a monitor so that he can see and do the operation. And I think that this is going to be thing. He said, I don't think something like this has happened. I said, I've read it in the Lancet. If you want, I can try to get the issue, but it's very difficult. In those days, there was no Google, there was no computer, so to retrieve an article was difficult. But I didn't meet him 5 years later in 95 in SGPGI and asked him, sir, I told you this. He says, yes, I remember. And now where have we come? We do laparoscopy, GJ, splenectomy, fundoplication, rectopexy, anterior resection. We have come a long way. And that's what I said, that human ingenuity will make progress. So the first laparoscopic procedure took so much time to do. But from that first procedure to doing more procedures took a very short time. And within 20 years, we were doing Whipple's laparoscopically, we were doing donor hepatectomies, we were doing major trisegmentectomies laparoscopically. As far back as 2005, I listened to the paper from Indiana University on 150 major hepatectomies, which meant right hepatectomies, left hepatectomies, trisegmentectomies done laparoscopically with a 1.5% mortality and complication rate. Fantastic results. This is 15 years ago. I'm sure it has improved now. So we have all these advantages. And once these disbelievers are given the long-term data, when they are shown that the results of surgery will be the equivalent of laparoscopy, when they find that the loss of tactile feedback is made up by improved vision, and the visual resistance that you see in tissues, you will learn. Like when laparoscopy began, we had the same problem. They said there is no tactile feedback, and then all of us developed tactile feedback with visual cues and with sensitive cues. The same thing will happen in laparoscopy, I feel. And so you will have, and the robot is going to be an enabler. You will do the same operation, but with much better results. And now we see a lot of advantages in clinical applications, especially in suturing in depth, doing aortic valve replacement, mitral valve replacement, aortoiliac bypass, in gynecology doing fistula repair, tubal reversals, fundoplications, whatnot. Yes, there are going to be some places where it is not going to be easy, but then this is where you have to learn your laparoscope. I have a robot, and the first 10 procedures I did were things like cholecystectomy and mobilization of colon, because these are the things that I could do safely without compromising patient safety. Now I've got more training, I can do them a little more precisely, and I can do it better. Yes, I still lack the harmonic scalpel or the vessel sealer because it's not commonly available in India, and when it is available, it is expensive. But I'm sure that they will bring it up, and once it comes, the robotic instruments will become cheaper. We'll be able to do more surgery. So you can have all these theaters which will look like, all arms done mechanically to show you the various things. And this will very well be the operating room of the future with an inbuilt CT or an MRI scanner, and the surgeon sitting at a console guiding the robot. And when he doesn't find what he wants, he can always use a CT scan immediately on the table to find out what he wants. If he can't see a critical vessel, he can inject some dye and see the angiogram. He can use ICG to see the vessels, and this will be the future. And now for the last couple of years, this is very freely available across the world. Even in India, it is available at a fairly high price, but it will come. And the overstitch endoscopic system where the physicians with their endoscope can make full thickness sutures with a flexible endoscope. This is the ultimate frontier. So we used to say that they can't stitch with an endoscope. They have overcome that. Now you have the technology to stitch, and when you see an expert using the overstitch, I have attended a class at the American College, at the American Surgical Society for Alimentary Tract workshop during the DDW, and I attended a 3-hour workshop on animals, and I saw this system. And the ones who know how to stitch it, they can do such a fast suturing, obesity surgery, GJs, they can all be done now with this overstitch system with very good results. So it fits on top of the scope. For Indians, what we can do is that we can use this for 2 patients. They use it for 1 patient. So we can half the cost for the patient, and then we use the sutures which are specifically made, and there is a shuttle-like device like the old endo stitch of the laparoscopic era, which is very efficient, and I found it also very easy, and I could do fairly rapid suturing. And I think that this is the future of surgery, and we are going to see many procedures taken away by our endoscopic colleagues. And all I can do is that I open your eyes to what is possible, and I want you to get passionate and say that you will also do this. And if all of you decide that no, I'm happy with doing open and laparoscopic surgery, there will come a time, like in the 90s, when I found that many of my colleagues who were general surgeons suddenly found that their hernias and their gallbladders were disappearing. They didn't do major GI surgery, so they were not doing that. But these were disappearing, and we were doing it. And the reason was that they didn't offer it laparoscopically, and patients would read and they wanted laparoscopy. In the early part in 1998, 97, when we were doing both lap and open, 80% of our hernias were done by open surgery because we never pushed for it. In 2020, 90% of our surgery is done laparoscopically because patients come and they ask for it. And if you don't give them what they ask for, they'll go to the next hospital that will do it. So you all have to get all these things. And you will have to form groups where each person can specialize into an organ and do all the things in the organ. Diagnose it, do the endoscopy, and if necessary, do laparoscopy or open surgery. And I think that is the way forward that we can see. Groups doing work where each one specializes in an intervention. And we will have interventionists and non-interventionists, not physicians and surgeons, but interventionists will do all the interventionists, and the non-interventionists will look after the medicines, because there's a whole plethora of medicines now available for treatment of so many diseases. And I think we have moved towards that age, and I wish my younger colleagues would do this, and I wish them the best of luck in their career. And thank you, and I'm open to questions.
Brilliant talk, sir. Congratulations. Though it is a bit provocative, there are a lot of medical gastroenterologists has logged in, like Dr. Roy Mukda is there, Dr. Ismail Siad is there. A lot of medical gastroenterologists are logged in, and we have the faculties like Bala Rao, Subhash Khanna, Bunithar, Rajesh Tike, Subramanyeswar Rao, Thomas Varghese. A lot of people are logged in. Sir, G.V. Rao, sir, you can take it forward.
Thank you, Ramesh. That's a phenomenal lecture. Actually, but for this virtual conference, you would have received a standing ovation for this fantastic lecture. Congratulations. It has been a real inspirational talk for all the surgeons. I'm sure a lot of medical gastroenterologists have logged in, but I think even they will accept to what Ramesh has said. Actually, there's nothing provocative about it, actually. Thank you so much, Ramesh. There are a lot of questions pouring, a lot of congratulatory messages from across the globe. I think you can see that subsequently, Ramesh. But there are also some questions from the audience. Like Obi Sudhir has been, like, he's got a couple of questions. He's been asking, like, do we have any friction that we develop between the medical gastroenterologists and the surgeons if we practice endoscopy?
Yes, this has the potential, but I think if the average general surgeon starts doing endoscopy, and most of the time he will be doing upper GI endoscopy, controlling an emergency bleeder, he will take biopsies, he will do a colonoscopy, take biopsies, but he is not likely to do ERCPs, endoscopic mucosal dissection, EMR. I think these are the areas where the medical people should be concentrating, along with the surgeons who would like to specialize into endoscopy. So I think doing POEM and things like that. There should be no real conflict of interest. I think the workloads can be split, and a lot of load. I know that in many public hospitals like All India Institute, to get an appointment for an endoscopy will take 2-3 weeks. And if suppose the general surgery department was to do the diagnostic endoscopies, the medical gastroenterology can be kept for doing the advanced therapeutic procedures, and the endoscopic diagnosis can be done by general surgeons who can take the biopsies, prove the esophageal cancer, prove the esophageal gastric cancer, and then take it to the tumor board and decide what is to be done.
Excellent answer, Ramesh. Actually, there were two ways of looking at actually what Sudhir actually, what you said is right. Actually, there could be some friction between the medical and surgical gastroenterologists doing endoscopy, but this happens in the tertiary referral centers. But if you go down to the three-tier cities, actually, I mean, most of the surgeons, even today, actually 60% of the endoscopy practice seems to be done by the surgeons only. So I think it is, it's a matter of where you're practicing, I think, but even today, 60% of the practice, endoscopic practice, especially in three-tier cities, is being done by surgeons only.
Yeah, but the situation in Kerala is a bit different. I think Dr. Roy Mukda and Ismail Sia is there practicing in Kerala. Actually, here the surgeons practicing endoscopy is less in Kerala. I do endoscopies and ERCPs and all, but there are a lot of frictions between the medical and surgical if you are doing endoscopy work. Probably the situation may be a bit different in Kerala.
When I was in AIG in 2003 or 2004, and we had an attendance of about 1,500 delegates, I actually polled the the audience, how many surgeons and physicians. You'll be surprised to know that 80% of the audience was surgeons. And I have come to know that in most places in Bihar, in West Bengal, in Orissa, surgeons do ERCP, they do everything because they don't have medical people available at the peripheral center. So they have to do all the things. They even do transurethral resections and ureteroscopies in urology. So they do a wide variety of work. So Kerala and Tamil Nadu have a lot of specialists. So I think that we tend to get the work done by specialists.
So the other thing, actually, Ramesh, actually, you know, actually the intraoperative endoscopy actually is becoming a separate specialty by itself.
Yes, yes.
I think significant practice. Actually, we don't have to do regular diagnostic endoscopy, colonoscopy. Even if you do the intraoperative endoscopy work, I think that itself contributes to a significant amount of.
So in my department, now that we have purchased new scopes for the endoscopy suite, we have taken the older scopes and refurbished them, and we have kept up in the theater so that we do a rectum, we do a fistula, and we do some procedure in the upper GI. We can immediately do an endoscopy. We just have to pull the scope up to the patient and do it. We don't have to borrow it or ask permission. So I think that this can be done, that the older scopes can be sent to the theater. And what we have done is that we have 2 DNB PGs per year and 1 FNB PG. So by turn, we post them into the endoscopy room. So once in about 7 or 8 days, they go and they spend the whole day in the endoscopy room. So they learn endoscopy. By the end of 3 years, they would have spent about 30, 40 sessions in the endoscopy room, and they do OGD and colonoscopies. They watch the others and they get an idea. And some of them, I hope, will become interested and will take up endoscopy in a big way.
Yeah, two things actually. Yes, what you said is right, Ramesh. And there is certain definite evidence to show that intraoperative endoscopy has definitely improved the outcomes in certain.
Definitely. I think sometimes you don't know how much to resect. Then the intraoperative endoscopy helps you to know what to resect, where to stop. So I think intraoperative endoscopy is a good learning method. Patient is under anesthesia, so you can take and they can teach and they can learn. And if you can't find the bleeder, you can do a small bowel enteroscopy and try to locate the bleeder.
Yeah, and the combined endoscopy laparoscopic procedures and the new specialty that is emerging called the endolaparoscopic cooperative surgery is also becoming a separate specialty. So I think surgeons should be abreast with what is happening so that they can do these combined procedures very safely.
Happy if you are giving a lecture on it in future.
There is another question from Dr. Mandar, who is asking about the medico-legal aspects of surgeons practicing endoscopy.
I think that if it is included in your curriculum, there is nothing that prevents surgeons from doing endoscopy. There is no law. So I don't think that you need not to be worried about doing endoscopic procedures. And even if you have a complication, you will be protected, because being a tertiary referral center, I get so many complications from endoscopists after ERCP perforations, after upper GI scopy perforations, and I manage them, and none of them have gone to court. We deal with them, and some of them have even died, but nobody has gone to court. And so I think it's just how you talk to them and how you do it. I don't think that we should be doing it. And we have brought it into the curriculum of GI surgery successfully in our meetings with the curriculum board, and we have now made it an essential part of GI surgery. And I think that we should continue to take it forward. And I know that there'll be a question by many people as to where they can train. There are many centers they can look for, but if some of them are really interested, they can come and spend. I can put them in endoscopy for a month or 2 months, and they can see a wide variety of procedures, and then they can go back. And many people have come like that and then gone back and practiced endoscopy successfully.
Yeah, Baiju, do you think there are any further questions that you could see? I don't see anything much on the screen here.
There are people, Girish Mallada wanted to ask some question. Girish, can you please unmute? Girish? I think he has gone. He has actually raised his hand and wanted to talk. Dr. Balarao is there in the audience? Dr. Subhash Khanna?
Hello, Baiju.
Yeah.
Dr. Balerao.
Yeah.
Hi, GB.
Hi.
See, I think Ramesh has covered everything very comprehensively in a brief manner. But what do we see whenever a patient goes to an endoscopist for a surgical problem? Do you feel that many times the procedure which patient receives may not be required? Is it still rampant? I do see that quite frequently.
It has become less, but I do see it still. And I'll tell you frankly, I mean it as no insult, but what happens is there are two types of medical gastroenterologists. One is who gets the fee for service. So when he does a procedure, he gets a fee. And the other is working at a medical college or a tertiary referral where he is paid a fixed salary, and it doesn't matter what procedure he does. I find that when they get the fee for surgery, last week I saw a patient who had a bilirubin of 2.1, and they did immediate stenting. And what happened is that he developed post-ERCP pancreatitis. When they went into surgery, they couldn't operate because there was a florid pancreatitis after 6 weeks of waiting, and they had to come out. So I think that yes, there is. So
I
now
think endoscopists have still not developed a conscience on that. Part of the I think their intervention. The second perception is about cholangiocarcinoma.
But I must say that to be honest, it has changed quite a bit. Many endoscopists do ask me should we do a side viewing scopy and biopsy, or do we need a stenting? So I tell them what I need, and then they follow the thing and they send the patient back to me when they do. So I think that some have learned, but some have not. And I think this is going to continue, that there will be people who will be over eager to do procedures and who will continue to do this.
I think the incidence will go down once we start practicing multidisciplinary meetings.
Yes,
I think that
yes.
is very important. And this sort of practice will cut down to practically zero. Unfortunately, it will take a long time for us.
And in a private hospital, I think a discussion between the surgeon and the endoscopist before the ERCP, so that you know what you are asking the ERCP man to do. You have a discussion. Are you willing to operate? So you look at all the parameters, the bilirubin, the albumin, the general fitness, the comorbidity. Is the patient willing to have an operation early? If not, then you will say that even at 9 bilirubin, you stent because he's going to come after 2 months because doesn't have money, or he has got a marriage in the family. These are all practical positions we have seen. So I think that we have to take that.
Yeah.
Thank you.
Can I ask about some limitation because he is contesting for some election? So he has sent me a message that he wanted to ask, tell that in the future there will be a situation that the medical gastroenterologist probably there will be a question from court that why they did an endoscopic suturing and cutting. Probably it is his guess actually.
I don't think that this will come. If you have a certificate saying that you've been trained in this during your course, or you attended a subsequent fellowship and you're trained in this, no court will allow that question. Somebody may ask, but they will say, no, he is trained. He has got these certificates and he has spent sufficient time. Of course, a 1-day, 2-day course may not work, but if you spend 6 months in a fellowship or a year in a fellowship, that will work.
Can I ask Dr. Roy Mukudak to unmute his mic? Actually, he's a medical gastroenterologist doing a lot of interventional endoscopy like POEM and all. Dr. Roy, can you please unmute? Yeah. Dr. Roy, say some comments.
Hello.
Yeah, tell me.
Yes, Roy.
Hello. Yeah,
yes,
can you hear me?
Yeah.
Hi.
Yeah, Roy.
Yeah, Baiju.
Your opinion regarding the talk and the concerns raised.
The talk was excellent. I appreciate Dr. Ramesh Rathnari for an excellent view on how the surgeons should go in for that. I agree for that, but the problem right now we are seeing is the training is very short for the surgeons. Very short period, maybe 2 weeks, 3 weeks training and doing endoscopy and getting into problems. So that should not be the way we should go in. If you have a proper training, meanings there should be a good curriculum which has been designed, and then it should be okay. Otherwise, it's going to be a problem.
That is why I said that surgeons should do. There are 2 parts. That is, one is basic endoscopy. So they can do endoscopic diagnosis of the upper GI tract and the lower GI tract, including a plain colonoscopy. And they can do control of bleeding. So these are the emergencies which they should do. But there is really, every general surgeon need not get proficient in doing an ERCP or doing endoscopic cystogastrostomy or an endoscopic GJ. That is not necessary. A few people who are inclined to it, work in high volume centers and can do it, they can do it. So I have never done an endoscopic GJ, but I've done plenty of endoscopic cystogastrostomies of various sizes. I have done a lot of POEMs because my medical gastroenterologists don't want to do this. They said, you do, we will see, and then we will come. So I have been training them. And actually now I hardly do ERCPs and all because they're well trained. So they do it, and I have other work. So I just go and do other work. So having passed on the baton to them, and to other surgeons, my surgeons are all trained to do endoscopy and ERCP. So they also do it. So I have now stayed away from doing it. There comes a time when you say that we have done enough, and I now stay away. I do less of open surgery, less of laparoscopy, doing it only for important patients because I have to train so many students and junior consultants. So I think that we have to accept that, and then we train people according to the level they want to be trained.
Yeah. Dr. Roy,
That's right.
Dr. Abhed Alvi wanted to.
Yeah.
Hi, Ramesh.
Hi, Abhay.
This was a talk from the heart. Let me tell you, this is not what is literature, and congratulations for that. Both of us, I think you must be senior to me, but I just want to ask you one question. We start everything as a novice, and then we slowly go on to getting better and better, and people call us experts. Somewhere down the line, you start realizing that you should not get into this. At what age do you think that one should say, I should not get into this because it's beyond me?
I think it depends on the complexity of the procedure. When I was younger, I was keen to start the liver transplant program in my hospital. But at that time, we didn't get cadaver donations. We didn't have cadaver. Now, when we started getting, and we could get into some memorandums with the RELA group, and we could start doing cases, I was almost 60. So I decided that I'm not going to be involved. I have spent 3 months in Birmingham training in liver transplant. But I walked out from liver transplant team, and I gave it to my second colleague who was interested in liver and liver transplant, and I let them do and they have been doing not only the transplant, but also the liver resections for the last 2-3 years. Even my cases, I send it to them, and I just stay in the theater to just observe. So there comes a time when we all have to restrict to what we do. So I decided that liver, we don't do too many cases, so somebody has to concentrate on doing it. Everybody does it. It is not, nobody is going to become an expert. So I talked to one person, he was interested, I channelized it to him, and I gave him the transplant program. I don't interfere with the transplant program. I don't even see the patients. So I think that I decided that at 60, it is too much for me to start, so I didn't start that.
Yeah, so my collective question to you and GV, who should be the endoscopy target as a surgeon? Who should be targeted?
A surgeon should first look for the diagnostic endoscopy, and they should look for doing biopsies. Then they should move on to doing banding and hemostasis. They can start doing sigmoidoscopies and then later colonoscopies, and taking biopsies, and maybe removing small polyps. And then if they are confident of doing this, if they feel they have good hands, they can move on to doing more procedures. So it's very important that
GV,
these
you
are
have
all.
any comment on this? Yeah, sorry, go ahead.
And this is a technical field. And those of you who have read Frederick Forsyth's book on the Afghan, you will find that there is a very nice statement that in matters of technical jobs, there are 4 levels of people who are there. There is the average, there is the good, there is the brilliant, and then there is the natural. And this holds true in sports also. So you can have good batsmen, but everybody cannot be a Brian Lara or a Sachin Tendulkar or a Rahul Dravid. That's a limited group of people. They are the naturals. For them, it comes naturally. They are born with an inborn talent. And it's true of surgeons that you have this ability to do in all these, and you have to find out by your 5th year or 6th year what is your level of comfort and stick to it. And the disasters occur when you are not up to doing the procedure, but because everybody else doing, you want to do the procedure, and then you get into trouble. And I never had that ego, so I was happy to leave liver transplant, because at my age to start doing such a long procedure may not have good results. So I stayed out from it. And I don't think of myself as a lesser surgeon for doing that. It is just that it was the age at which it came. So I said, hands off.
Very nice. I think that's the message I want you to take across, that everybody should not put their foot into endoscopy, GV, I have a question for you. Are you listening?
Yeah. Go ahead. Yes.
GV, tell me, if you take up surgical endoscopy as your profession, should you meddle doing laparoscopic surgery as well?
Yeah, this is actually a very good question. Actually, the first thing actually surgeons taking endoscopy, I think we should suppose doing upper GI colon, maybe you can start at any given period of time. But endoscopy is getting so subspecialized and so advanced. And even now the endoscopists are limiting themselves to certain specialties. And it would be unfair for anybody to get into advanced endoscopy procedures thinking they can do everything. So I think we have to, people who are passionate about endoscopy should only practice advanced endoscopy, should practice only endoscopy, and they should not be doing combined this. We could still be doing routine work, but I don't think it's possible to devote completely and do a complete justice to endoscopic practice.
And we have outstanding examples in this country. Amit Medev, Amol Bapai, Vipul Rai Rathod, who have gone completely into endoscopy. They don't do open surgery, they don't do laparoscopy, they do only endoscopy, and they do a wonderful job. I think those who want to do advanced will have to do that movement laterally.
Thank you so much. And thank you, Baiju, for allowing me to ask this question.
Thank you, sir, for asking question. Dr. Varghese Thomas, he is an oncosurgeon practicing in Cochin. Dr. Thomas Varghese.
Hi.
Yes, sir.
Dr. Ramesh.
Yes, I can hear you. I can see you.
Yeah. I think this is one of the most provocative lectures of recent times. Already, Baiju has told the scenario in Kerala. Forget about Kerala. I am actually trained in Tata Memorial for my oncology. And during our times, there was only 2 gastro people in our hospital. So most of the endoscopies we had to do because of the sheer number of patients. So esophagoscopy, gastroscopy, colonoscopy are all work. But coming back to Kerala and tell that, see, I'm trained in Tata Memorial. We have been doing all these endoscopies. How many endoscopies will permit? This is number one question. Okay, that is a practical question. But the reality, when I went to Japan for Surumaru to learn esophagus in a 3-field dissection and all, we saw the first beginning studies of endoscopic mucosal resections in the hospital. Most of it was done by the surgeons who are enthusiastic surgeons, doing all this adenosine green and dye staining and going for the focus and doing the resection and all. All said and done, in practice, I think a surgeon who is going to operate on a hollow viscous should see by himself what is inside before he cuts. Many a time we get a stomach diagnosis. That is, there's a lesion in this much distance from the esophagus and adenocarcinoma, and the endoscopy reports mostly ends there. There's no mention about how is the lesser curvature, how much is the greater curvature involved, or how much far from the G junction the tumor is, how is the
your voice has become.
Your voice suddenly lost.
all these issues. Am I audible?
No.
Dr. Thomas Varghese, your voice is low.
Hello?
Yeah, now it's audible.
Audible?
Yeah.
Yeah. So practically, when I think my screen is gone.
Okay.
Is it okay?
No.
It's okay. We can hear you.
I think anyway, am I audible?
Yeah, now you're audible. Yes.
Okay. So from practical point of view, as Dr. Ramesh clearly said, for a lesion in the rectum, how much it is from the anal verge? Most of the time, it may not be accurate to do a sphincter saving or not. So therefore, I think even if a gastroenterologist has done an endoscopy, no harm in cross-checking and finding out for yourself
before you attempt to operate a patient. There is no harm in that. At least that much thing should be the take-home message. It's my personal view and opinion. But thank you very much for such a wonderful lecture. I mean, you have taken it to the robotic endoscopy, even which I don't know it is going to come up immediately, but still. So such thoughts always starts from a spark, and this spark is most important for the juniors to develop. As you said, everybody may not be natural, but at least to put effort to become near an expert is to be inculcated in the junior level. So for that, I think this lecture is fabulous, fantastic, and excellent. I would say a thought-provoking thing for the people who heard this. Others really missed it. Thank you so much.
Thank you, Dr. Thomas.
Thank you for the compliment.
Thank you very much.
I request Dr. Punithar, because he has given some opinion in the chat box. Dr. Punithar, please.
Hi, congrats, Ramesh and GV. I think a fantastic session. I must confess, I've asked GV on several occasions, why do you think, and Ramesh as well, why do you think surgeons should do? And I think time has proved me wrong, that they were right. If you look at history, all the relevant endoscopic interventions which happened were done by surgeons. It was Tablanche, a South African surgeon, who actually did the variceal, sclerosis and all that, which ushered a therapeutic endoscopy to a large level. The ERCP was done by the European surgeons. GV himself, even being in a good center with excellent endoscopy colleagues, has proved that, his excellence in this has actually been a stepping stone for surgery to advance. Ramesh has shown, from the South in an area which is being drained by people where you don't have access to endoscopists, and he's proved. So I confess I've been wrong all through. I think you make a very strong case for training of surgeons for endoscopy. And I think I tend to agree with Abhay that it should not be everybody, but we should have in each of our teams some people who must take, just like some people should take up research, some people should, excel in something. I think we should make sure that we have endoscopy in our armamentarium so that we develop. It's not about competing with the gastroenterologists because they're excellent, but I think we can take it to a different level. We can take surgery to a different level. So I really congratulate both of you for an excellent, proof of what you actually, you walked the talk through your lives yourselves.
Thank you, Puneet.
Puneet, and Dr. Subramanian Rao is written something in the chat box. Dr. Subramanian Rao.
Yeah, wonderful talk, Ramesh. I've actually admired both these gentlemen, both Ramesh and GV, for a very long time. I've been following them. Surgical oncology is a field which was a little late in picking up minimal access surgery, and that's where Ramesh was a real inspiration. And then GV, of course, has been an elder brother. We continue to work together. I think this talk, the selection itself and the selection of the speaker and the moderator has been phenomenal. Baiju, you need a pat on your back. I don't know. I'm a little more pessimistic. While in Kidwai, I was trained as a resident completely. Those were the days when a patient that I am working up, upper GI scopy, colonoscopy, bronchoscopy, DL scopy, cystoscopy, all the scopies had to be done by the particular resident. So you see outside, and you see inside also, because once you see more, once you see better, you actually do better. So that was the philosophy. But when I came to Hyderabad, the ecosystem, because there was no gastroenterology department at all in Kidwai, that was probably a blessing. And when I came here, I lost these skills in a few months because I got sucked into open surgery then, and then learning minimal access surgery. So have we gone too far from where we can retrieve ourselves? I have a lot of respect for leaders like Ramesh, GV, and others who have held on to the scope, and maybe they should actually save the horoscope of the surgeons in the country.
Yeah, I think this the whole thing stems from the hubris of our seniors. They saw this thick endoscope peering through small light, not a good vision, and they said this has no future, and they gave it up to the physicians who didn't at that time have much work. They didn't have much drugs, so they would just be giving IV fluids for diarrhea and nothing else. So they gave it to them. And you see, this is what we forgot, that humans are tremendous innovators. And once they have an idea, they will go anywhere. And that's exactly what has happened in every field. As I said, from aeroplanes to cars to computers, every field. I don't know how many of you know that in 1948, the chairman of IBM, a gentleman named Watson, made a statement that I think that there are about demand for about 5 or 6 PCs in the world. That's all. And you know how wrong he is. And a gentleman who is even more famous, Bill Gates of Microsoft, and when he made his first PC, he said 648K kilobytes. That was the RAM of that PC ought to be enough for anybody. His Windows 10 requires a minimum of 8 GBs of RAM to load and run. So you know how the people have made mistakes, even great people like Bill Gates and this thing. As a matter of fact, Bill Gates, IBM signed the rights for MS-DOS system to Bill Gates. And that is how Microsoft became such a big company. Otherwise, it was IBM which started MS-DOS. And they should have been the software giants of the world. And they thought the money was in hardware, not in software. And how mistaken they were. And that's the mistake our juniors should not make. Endoscopy is going to dominate the landscape in the next 3-4 decades. I won't be around to, because I am coming at the fag end, at the evening sunset of my career. But these are youngsters and they should fight so that they will be able to be relevant in their work.
Yeah. Dr. Lashmikant, our regular attendee. Lashmi, can you please unmute?
Yeah. Sir, excellent, sir. I think Ramesh and the GV Rao, and as you know, Ramesh, he was always a teacher. Every time we used to work with Palani, we know that he was doing both laparoscopic and very good in endoscopic procedures. And a lot of procedures, we have learned from him through his workshops. And GV Rao, we used to think, we used to hear that, one of the excellent person in ERCP, sometimes better than Guru, we used to hear, and in his pre-cut and everything. So I think during our stay with Palani, we realized that he used to always say, I think you should do your own endoscopies and colonoscopies, and even your laparoscopic ultrasounds and everything. So sir, it's a very great lecture, and for a lot of youngsters, that we should not give away endoscopy, and we should at least start with diagnostic. If at all we are interested, we should go forward. Many of my colleagues who have visited GV Rao have become pioneers in spy endoscopy, ERCPs, and they're doing very good in Coimbatore. So just 2 weeks visit. That's what a surgeon, when he wants to do, he makes it ERCPs looks very easy. So I think surgeons should not lose out. And as Ramesh sir has rightly said, I think we should not leave the endoscopic work. We should keep working on it. Thank you, sir. Thank you.
Yeah, actually, there are a lot of questions from in the chat box regarding training programs. Dr. GV, can you please?
Very good question. Actually, Beju, there are multiple centers that are offering this training for surgeons. Now, basically, the biggest issue now is that because with so many DNB and MD residents on the medical side, to get hands-on experience in most of the centers seems to be getting difficult with the number of postgraduates increasing on the medical side. But there are centers which are offering this short hands-on courses both on humans and also on live animals and tissues. And some of them are getting trained on simulators, which are absolutely very good. So I think simulation training, tissue training, animal training would help train these surgeons, and also observing a lot of procedures in high volume centers, I think should be a good option for people who want to start upper GI and colonoscopy procedures.
Yeah, Dr. Marty Philip from Cochin, he is the Sachin Tendulkar of medical gastroenterology in Kerala. Dr. Marty Philip.
I think you've underrated him. He is a Sachin Tendulkar all over India. He is one of the leading endoscopists of the country. So I don't think that he is limited to Kerala.
Yeah, I'll invite you, Dr. Marty Philip. Please unmute.
Yes, can you hear me?
Yeah.
Ramesh, thanks for your kind words. I was just listening to all this. This is a big question, but I think, my perception is different. I think gastroenterology training, what I'm talking is medical gastroenterology training has become diversified. Now you have got hepatology, luminal gastroenterology, and endoscopy. In endoscopy, you have something called diagnostic endoscopy and therapeutic endoscopy. And also in therapeutic endoscopy, now you have got something called a flexible endoscopic surgery. So I think flexible endoscopic surgery, surgeons are the best people to do that. And you know that there is something called a hybrid surgery where surgeons score over everything. And surgeons are mostly, most of them are very confident and they know the so-called surgical anatomy better than us. So I think when you do a diagnostic endoscopy, the time has gone by just doing diagnostic endoscopy looking for a tumor. Now you have got image enhancing endoscopy where the endoscopist has to be very skilled. You have to do a narrowbanding imaging, or you have got endocytoscopy. You have to mark the tumor, identify the tumor. There are so many things in that. So just doing a diagnostic endoscopy by anybody is not really correct. So actually we have to plan and do. And there is no doubt that surgeons should be trained for endoscopy. There is no doubt. And I always believe surgeons should be trained for endoscopy. And in the future, so-called flexible endoscopy surgery will be done by surgeons. That is what I think. It will become going to be a specialty. Endoscopy is going to be a specialty, just like what in many countries where surgeons are mostly doing it. Thank you so much.
Thank you.
Greetings.
Another thing, Matthew, you see, in most hospitals, you will have about 3 or 4 surgeons, and you will have maybe 1 or 2 gastroenterologists. If the 2 gastroenterologists want to go for a conference, then the endoscopic services should not stop. So there should be a backup, and the surgical people will be ideal backup to at least tide the crisis till you come back.
No, but when the surgeons go for conference, medical gastroenterologists don't do the backup.
That is a problem. So that is why most hospitals have 3 or 4 surgeons, and 1 or 2 stay back whenever the others go for a conference.
We have got 7 people. So conference.
In your hospital is an exception. I'm talking of most private hospitals. There are 2 or 3.
What I think is, both surgical, I don't even call it surgical and medical gastroenterology. It's gastroenterology and then GI surgery. And I think, that you people are also going for minimally invasive surgery. So flexible endoscopy surgery is the future. That is what I think. I am sure.
I think it's I totally agree. It's the future.
JV is behind that, I'm sure. So that.
Yeah, and I think you're going to see more and more of it in the next 2 decades. And many surgeries that we now do by laparoscope are going to be done by the endoscope.
I'm sure about that. So thank you so much. It was a wonderful lecture and all comments. And I know that the answer is not easy for this question. Who should do the endoscopy? And
it's not easy, no.
It's not easy. And I believe that this is your passion. Suppose a surgeon who wants to do endoscopy, it is his passion. He should concentrate only on that. And medical gastroenterologist who is interested in IBD, you should do endoscopy for those things, and you should not go for any advanced endoscopy. And a physician who is interested in advanced endoscopy, I think he can go out and then do extensive work. Because there is a lot of things, you told the surgeons can do banding and all, but I don't think so. Because, managing cirrhosis is a very complex program. Just putting a band is different.
No, just for the emergency control.
There are so many things involved in that. Sometimes,
suppose they can control. Suppose you're in Rajapalayam, which doesn't have near 100 kilometers, a medical gastroenterologist, and there's a bleeder. He can do an endoscopy, put a clip, and then refer it to the, or put a band and refer it to the nearest gastroenterologist to manage further.
Why I'm telling is, sometimes in the night you are called for endoscopy, and the young colleague does an endoscopy. He says that it is not from the esophageal varices, it is somewhere the gastric varices are very huge. Then we do a US guided procedure at that time. Or
I know.
Or taking for TIPS procedure immediately. No, that's what I'm telling you.
Yeah, okay. True. So true. So obviously, if you're in a tertiary care, you can do all that. But I know that there are many physicians and surgeons who are working in very small places who don't have the backup. So they have to do something in emergency, stop the bleeding. If nothing, at least put a Sengstaken and Blackmore tube and then refer the patient, to tide the crisis.
Okay, thank you. Thank you for asking my comments, Snap.
Yeah. Thank you for joining. Actually, there are a lot of medical gastroenterologists joined. Actually, we have got a WhatsApp group for this topic alone, endoscopy and surgeon. And with the permission of Dr. Ramesh Ardhanari and Dr. G.V. Rao, I include you in this WhatsApp group. At least
Sure.
There are a lot of questions people are shy to ask. So I'll be adding you to people, at least for a week, that they'll be asking questions. Please answer to them.
Certainly, I think we'll do that.
G.V. sir, for the final comments.
Thank you, Baiju. Again, I should congratulate Dr. Baiju for starting this foundation and for starting this series of lectures, which have been incredible. Actually, the topics, the faculty that he's been choosing is incredible. The messages are very clear, and I think it is inspiring and also updating a lot of surgeons, junior surgeons and senior surgeons alike. Thank you so much. Actually, I just wish, Baiju, that you should continue this endeavor. Wishing you all the best in your future endeavors. Thank you so much for involving us. And Ramesh, thank you so much. I mean, we've been interacting so long. It's an incredible, as I told you, if it were to be a routine lecture, you would have got a standing ovation for this. Thank you so much for a beautiful lecture. And it's been a real inspiration. I'm sure a lot of surgeons would get inspired, at least make an initiative to do some endoscopic work, which would ultimately benefit not myself or somebody else. It is ultimately in the interest of the patient. Nobody is doing it just for the heck of it. Actually, we are doing endoscopy procedures in the interest of the patient. So I think ultimately the patient is going to be the beneficiary. It is not the endoscopy surgeon or the endoscopist who should do this. I think we should keep the patient in mind. Incredible lecture. I think it should inspire a lot of younger surgeons to do some endoscopic work, and maybe some of them can take up endoscopy as their practice. Thank you so much for involving us, Baiju.
Yeah, thank you, sir. Ramesh, sir, still 110 people are there logged in. That means dil mange more.
All I can say is that you have done a fantastic job. You organize it very well, and so a lot of people have come in. And I am so happy that so many comments and questions. That shows that surgeons are, a lot of surgeons are interested in endoscopy, and I hope that this continues. In Tamil Nadu, what I've noticed is that the MCH GI surgery graduates, they all do endoscopy. So in Tamil Nadu, a lot of surgeons are doing endoscopic procedures across from Nagarkoil to Tanjavur to Salem. So they do a lot of these endoscopic procedures, and I am very happy for that. And ultimately, we must thank Professor Rangabhashyam for having started this specialty, where I think that it has opened the horizons so much for general surgeons. Thank you, Baiju.
Thank you. Thank you so much.
And, actually, we, Sainadhavan Education Foundation, is honored to have you two stalwarts in this platform, and other faculties have joined. I thank all the participants who have joined from all across the world to hear this talk. Thank you all.
Thank you so much.
So good night, and I hope that we will continue to meet